Tracheostomy is a procedure performed with relative frequency at tertiary care children's hospitals. While children receiving a tracheostomy have a high overall mortality, deaths are usually related to the underlying disease and associated conditions, not the tracheostomy itself. The number of pediatric tracheostomy procedures is decreasing nationally. Anecdotal information suggests that physicians may be more reluctant to perform tracheostomy except for special clinical indications. Prior to performing a tracheostomy, it is critical to maximize medical management before surgery. The indications for tracheostomy in children can be organized into the following categories: neurological, obstructive, pulmonary or respiratory failure, and other causes. Neurological indications include hypotonia or low muscle tone and dysphagia or difficulty in swallowing, central apnea, and bilateral vocal cord paralysis. Obstructive indications include stenosis, tracheomalacia, the presence of masses, and craniofacial issues. Vocal cord paralysis also falls under this category. Pulmonary and respiratory failure in children who are ventilator dependent may drive the decision to perform a tracheotomy. Finally, there are a number of other rare conditions that can drive the need for this procedure. The diagnosis and medical status will define the timing of the tracheostomy procedure. The anatomy of the infant larynx is unique and is related to both age and physical development. It is essential for pediatric airway practitioners to understand the influence of age on laryngeal dimensions. Differences between adult and pediatric patients include the position of the larynx relative to the vertebral column, the composition of the cartilage and tissues, and environmental adaptations. The infant airway is more reactive than an adult airway and thus prone to developing laryngospasm. The infant larynx is estimated to be approximately 1/3 the dimension of the adult larynx. There are many factors that influence the selection of a tracheostomy tube for a pediatric patient. The first decisions to be made are related to the inner diameter and the outer diameter. In making this decision, you are balancing two competing needs. You want the largest inner diameter possible to maximize airflow and minimize work of breathing. At the same time, you want to minimize the outer diameter to avoid tracheal trauma and contact with the tracheal wall. The length of the tube must be selected in order to achieve safety and comfort. If it's too short, it will not remain in place. If it's too long, it may impinge on the carina. Because neonates are physically smaller than other patients, tubes designed for neonates feature a much shorter tube length. Another major difference between neonatal and pediatric tracheostomy tubes is the design of the flange. The short neck anatomy of the neonate requires a flange angle that is essentially flat or straight. As children age, the neck anatomy becomes longer. Because of this, flanges on pediatric tracheostomy tubes will typically feature a more pronounced upward angle. While most tubes for neonatal and pediatric patients are cuffless, cuff tubes are also offered to address the need for ventilator support when circumstances call for that solution. The neonatal tubes in the legacy Shiley product line are all cuffless. Extended length cuffed and cuffless trachs and custom-made trachs are also available in the Shiley Pediatric product line.